Oh, good.
Good afternoon, everybody, and welcome to our weekly Monday deep dive. I'm not the chair today, so I'm just going to quickly do a few general housekeeping things before I hand over to our host, who is Professor Johnny Mshlangu. So first of all, just to say that this is a weekly meeting we have primarily focused on our trainees, whether they're from Hempath, ClinHem, or any other specialty with an interest in clinical hematology. You are all super welcome. And once again, like always, very welcome to share the invite with any of your colleagues or friends. We'd be very, very happy to have them with us. So this weekly meeting is CPD accredited, so that happens automatically. We send through the attendance directly to the HPCSA. Around 5 o'clock, you will have a link in the chat box that you can click on and register your presence, and then make sure that way that you get your points. Please do not put your details in the chat box for those purposes, because they will get lost. Nobody will look at that afterwards. Feel free to add any questions, comments, suggestions, thoughts as you listen to the chat, but there will also be an opportunity to ask questions after the talks and between sessions. Prof. Mshlangu will indicate how, what, and where later. So with that, and without any further ado, it is my great pleasure to introduce our chair for this afternoon, Professor Johnny Mshlangu, who is Professor of Hematology in the Faculty of Health Sciences at the University of the Witwatersrand. For those outside South Africa joining us today, that is in Johannesburg, near to the northeastern parts of our country. Johnny also works for the National Health Laboratory Service. He's a consultant clinical hematologist in charge of hematology at Charlotte Masheke Johannesburg Academic Hospital. And he also received both his under and postgraduate training at WITS, which is our short for Witwatersrand. And with a special interest, and definitely not only a national leader, but an international leader in the field of bleeding disorders, in particular haemophilia and associated diseases and rare bleeding disorders. He's received many awards. Most recently, he received the Wits University Vice Chancellor Academic Citizen Award, as well as the American Society of Hematology Global Capacity Building Award. And he is in the Publon's top 1% cross-field reviewer. And for that, he also received an award. To make it more interesting, he had the Wits University Vice Chancellor Research Award in 2020 as well. And he is an elected member of the Academy of Science of South Africa. And he also most recently received the International Society on Thrombosis and Hemostasis Esteemed Career Award in 2021. Johnny, it's a great privilege. Congratulations on all those amazing achievements. And we really look forward to your talk, but I'm going to let you introduce both your talk and your speaker afterwards. I will be in the background to co-chair, but you are now officially the chair of this meeting. Thanks, Johnny.
On my side, I don't know if it is. Can everyone hear Vernon very well? Because I'm badly.
No, the sound isn't as good as it normally would be. So, yeah.
Okay. So it's not my side, it's Vernon's side.
No, it seems to be an issue, but let's hope it gets better.
Fantastic. Yeah.
Sorry about that.
Well, thanks very much. Yeah. Thanks very much, Vernon, and good afternoon, colleagues from South Africa and around the world. Good morning, good afternoon, good evening, wherever you are. Absolute pleasure to be invited by the UCT Deep Dive team to participate in this platform, and we're always delighted to be part of this education platform. Today, you're going to hear from the vets, myself and Dr. Lowe. Dr. Lowe, perhaps maybe I should introduce her now so that at the time when she does her presentation, at least we don't waste a lot of time. She is a senior pathologist in the Department of Molecular Medicine and Hematology at Vets, having obviously graduated at Vets like myself. And her interest is in hemostasis and thrombosis. And Susanne runs our hemostasis and thrombosis lab. In fact, that is what she's going to talk about. The session should allow a fair amount of discussion. Susanne and I feel very strongly that these sessions should not consume all the time completely and not allow the interface and the interaction we all desire in these kind of platforms. I'm going to kick off with a presentation which is in fact not in any way overlapping with that of Susanne. And I'm going to talk about prophylaxis, that it should be the standard of care in bleeding disorders. And my presentation is going to be about 35 to 40 minutes, and then I will hand over to Susanne. These are my conflict of interest disclosures, largely reflecting my interface with a fairly large number of role players in the clinical trial space. And the agenda for today, a relatively straightforward agenda. I'll review the pre-prophylaxis hemophilia management outcomes. I will then identify the key drivers for us to transition to prophylaxis in the management of people with hemophilia. I'll then summarize the WFH guidelines, and I'm aware that most of the attendees in this meeting, in fact, are familiar with those, and perhaps focus them largely on the relevance of the guidelines in us adopting those guidelines and coming with our own consensus recommendations for prophylaxis in South Africa. Factor following a bleeding event. In other words, it is a reactive process. And the intent is to actually limit the extent of the bleeding. On the other hand, prophylaxis is regular replacement of the missing clotting factor, which is often given in anticipation of or with the intent to prevent bleeding. In other words, a proactive approach. This definition of prophylaxis, in fact, has recently been updated in our definition of prophylaxis that we published last year. And the new definition includes the fact that we do want patients with bleeding diathesis who are on prophylaxis to live active lives. And that is probably a most important element of the modification of this definition. And the reality in 2022, all of us accept that prophylaxis is the new global gold standard of care in the patients with hemophilia. Just to remind you that we've come a long way. In the pre-prophylaxis therapeutic tools were limited, largely around blood and blood products, starting with the use of whole blood, culminating with the use of cryoprecipitate in the 1960s, when Judith Poole came out with the formulation for cryoprecipitate. And of course, in the subsequent years, in the 1970s, we have then made the products to have a longer shelf life in the form of concentrates, starting with plasma-derived clotting factor concentrates. And when DNA technology became available in the 1980s, we then formulated the recombinant clotting factor concentrates. And there's no doubt in my mind that, in fact, these pre-prophylaxis therapeutic tools are still relevant in many parts of the world, and certainly in our part of the world. And they have shaped the natural history of hemophilia in many parts of the world. We do know that the hallmark of hemophilia is hemathriosis or intra-articular bleeds, as shown in this picture on the left knee. And in fact, in a subset of patients, some of these patients somehow establish a vicious cycle of bleeding, leading to fragile blood vessels, leading to neovascularization, leading to more bleeding. And of course, establish a chronic synovitis cycle. Whether the patient does or does not have chronic synovitis, the bottom line is that all joints that have ever bled ultimately get destroyed. As you can see in this third diagram, this individual has got bilateral end-stage arthropathy, and of course the characteristics of this end-stage arthropathy is joint dysfunction, as shown by this radiologic evidence that there's no joint space. These joints, in fact, are not moving at all. The good news, of course, is that we've moved on, and I just want to review some of the consequences of not putting patients on prophylaxis. And I'll give you a number of these studies that best illustrate the point. The first one is the AHEAD study. This is a study that was a European study conducted over a period of 3 years in patients with haemophilia. Shown on the left, you can see comparing the mean number of bleeds over the 3 years that this study was conducted in. There's no doubt that whether one is looking at annualized bleed rates in blue or annualized joint bleed rates in orange, all the patients in fact had were a number of bleeds in the 3 years. Bearing in mind, of course, that this study was conducted in a European country, in the UK, where the practice of prophylaxis is actually very high. But this was actually an observational study when patients were not on prophylaxis, clearly illustrating the impact of not putting patients on prophylaxis. And the table on the right illustrate better the extent to which one is seeing the damage that is being done to the joints. And if one is looking at the treated bleeds, there were just over 870 bleeds in those who were receiving episodic treatment when compared to those who were receiving prophylaxis treatment. If one is looking at all bleeds, over 1,000 compared to 189. And of course, if one is focusing largely on the cause of bleed, and it really didn't matter whether one was looking at spontaneous bleeds or traumatic bleeds, there was a significantly larger number of patients who were getting bleeds when they were receiving episodic treatment. Admittedly, the numbers are a little bit on the small side, I must admit. We're talking about 45 patients that were included in the episodic arm and 49 in the prophylaxis arm. But I think the AHEAD study makes the point that prophylaxis should not be continuing to be the standard of care in hemophilia. We conducted this study, the HemoCare study, in 4 countries. These were developing countries as opposed to the AHEAD study, which was in developed countries. And in fact, the data was not different. I'm showing here the pre-prophylaxis joint health score. This was an epidemiological observational study where we looked and measured the joint health in our patients in the 4 countries. This was Tunisia, South Africa, Oman, and India. You can see on the left that the HJH score was uncomfortably very high across the age groups, whether one is looking at pediatric groups, adults, and looking, of course, at all the patients. The score was very, very high. And if one were to break down the HJH score by joint and site, comparing left and right, in the elbows, the knees, and the ankles, in fact, the picture was equally dismal. There isn't a single joint where the HJH was, the Patterson score was 0, clearly indicating that episodic treatment is no more acceptable as the standard of care, leading to, of course, unacceptable joint outcomes. And just to remind you that perhaps until very recently, we even had policies and recommendations around the care of patients. And the one that still puzzles me is the first one. We used to advise patients that if you are in doubt whether you have a bleed or not, just treat yourself. And you'll see how, in fact, that has changed. We used to start prophylaxis after the first bleed. That was an official recommendation by many organizations, including the ISTH and the IPSG. We used to convert patients from severe phenotype only to mild phenotype. We're aiming for about 1% factor level. And of course, that is in 2022, we do know that is not acceptable anymore. And of course, our expectations of the life expectancy of the patients wasn't great at all. This is data that was collected in the Netherlands by Hassan and colleagues. And I want you to focus on the graph at the top. And the graph at the top is an indication of the life expectancy of the general population. You can see that, in fact, in the 3 cohort years, from 1973 to 2001, at least in the Netherlands, the life expectancy was increasing. And yet, if you look at the severe hemophilia patients in the Netherlands, the life expectancy was actually going down. This is in the pre-prophylaxis era. And I'll show you data later to say that, in fact, prophylaxis has actually had a major impact in these patients. So there is an absolute need for us to transition from treating patients episodically to putting them on prophylaxis. And these are some of the drivers for switching patients to prophylaxis. Poor patient outcomes, as I have indicated in the AHEAD study, as well as the HemoCare study. Those are high bleed rates, the progressive arthropathy, despite being cared by professionals who know the disease very well. Poor quality of life are some of the outcomes. Suppose the biggest compelling data come from the clinical trials as well as the real world experience that, in fact, prophylaxis is more acceptable than episodic treatment in the management of patients. And finally, there is persistence of unmet needs in hemophilia care. Such unmet needs include immunogenicity, in other words, the development of neutralizing antibodies against replacement therapy, the high disease and treatment burden, and I'll illustrate some of that later, and the failure to achieve steady state hemostasis. You will later on learn that, in fact, steady state hemostasis is very critical in the care of patients with bleeding diaphysis. So we have actually moved on and started to switch patients to prophylaxis. The most important reason for switching is actually, beg your pardon, is the fact that the therapeutic goals have also evolved and changed over time. You know, if you look at this diagram put together by Mark Skinner, literally it tracks our intentions over the years. We're very happy to keep the patients alive right at the bottom and to prevent premature death. That is not acceptable anymore. We do know that these patients don't die. And in fact, we are aiming for normal hemostasis, which is right at the top there. And we want to optimize health and the well-being of the patients. And of course, anything in between is not static. It's moving and changing over time. So that is probably one of the most important reasons why we have transitioned to prophylaxis. How have we transitioned to prophylaxis? We have had to expand our therapeutic toolbox, not just using the plasma-derived products and the early first generation clotting factor concentrates. We've added the extended half-life products with improved pharmacokinetics. We've also added a number of evolving non-factor therapies. And we'll talk about some of these non-factor therapies and the importance of them driving the move towards prophylaxis. As a consequence of which, in fact, we've seen this exponential consumption of clotting factor around the world. Estimates are that the consumption is increasing all the time. As of 2020, we're sitting at around about 11 billion units of recombinant factor and plasma-derived factors being used around the world. And we'll talk about the reasons why it is not available to everyone around the world. But the bottom line is there is more than enough in the world to be able to put every patient on prophylaxis. And I just want to perhaps highlight the importance of these additional therapeutic tools. The extended half-life have actually reduced the treatment burden in patients with hemophilia. Shown at the top is the pharmacokinetics of standard half-life factor 8. If you are giving it prophylactically 3 times or 4 times a week, of course it is characterized by peaks and troughs. And in fact, if you try and extend the intervals of giving this, you end up with patients with bleeds at the trough levels where, just before the next dosing regimen. With the introduction of the extended half-life and exemplified by the graph below, you can see that in fact, you actually just need to give the patient a dose once a week in the majority of these patients, and therefore reducing the treatment burden of these patients. The advantage of extended half-life go beyond just reducing the treatment burden to include a very high efficacy level. What I'm showing here at the top is adolescents and adults efficacy of the 4 extended half-life factor 8 concentrates, and I've just summarized their median annualized bleed rates when they are given prophylactically at least once a week or every twice a week. You can see that overall, in fact, the bleed rate is less than 4 bleeds per annum, essentially translating to 1 bleed every 3 months, which is relatively low in the context of our patients. In fact, a similar picture is seen in the pediatric patient, and I'm showing here the 3 extended half-life that have been evaluated in pediatric, and you can see that the median ABR on prophylaxis is also low, less than 3 bleeds per annum. Across the 3 products at the end of the day, with of course varying degrees of bleeding with each of those products. So if one is looking at the impact of non-factor therapy on bleeds, it is huge. And I've taken at least one example here. The reason I'm using emicizumab is because it has completed at least 5 phase 3 studies. And this is a summary of 4 of those 5 phase 3 studies, which was published in Blood at the end of last year. You can see in this summary, on the y-axis is the calculated mean ABR, and on the x-axis is the time on emicizumab prophylaxis across the board. The first column is the summary, and you can see that in fact, once the patients are put on emicizumab prophylaxis, their bleed rates go down and stay down over time. And this is across all studies, across all age groups. And in fact, you learn later when you learn about emicizumab trials, that is, it is actually across the dosing regimens. Some of these are receiving, the patients are receiving emicizumab once a week, or every 2 weeks, or once every month, depending, of course, on each of those studies. Of course, that is not the only example. This is evolving data out of the RNAi, fitusiran, that was presented recently. You can see that, in fact, the impact on bleed rate is huge. On the left, you can see the median annualized bleed rate in patients without inhibitors, from 12 in those who are receiving on-demand treatment to 2 in those who are receiving fitusiran prophylaxis. Similarly, in the context of patients with inhibitors, you can see a significant reduction in their annualized bleed rate from 42 when they are on-demand treatment to just 1 bleed per annum. And of course, a small number, but nevertheless makes the point that the non-factor therapies are extremely efficacious in preventing bleeds. And if one looks at additional armamentarium that we've got at our disposal, we can still use the clotting factor concentrate. Of course, we've got a diversity of prophylactic regimens that one can use with the clotting factor concentrate. If one specifically is looking at the clotting factor concentrate by intensity of treatment, we've got 4 options. The first option is that of high dose regimen, which is often not affordable in many parts of the world, including, in fact, in the countries of origin, which are largely the European countries. In this regimen, the patients received 25 to 40 units of factor 8 per kilogram and 40 to 60 units of factor 9 per kilogram, given 2 to 3 times a week. We're talking about a total dose of just over 4,000 international units per kilogram per year per patient. Very, very high indeed. And if one is looking at the intermediate dose, and sometimes referred to as the Dutch regimen, slightly lower than the high dose regimen at 15 to 25 units for factor 8 and 20 to 40 units for factor 9, given 2 to 3 times a week. And we're talking about the total dose of 1,500 to 4,000 and 2,000 to 4,000 for factor 8 and factor 9 per kilogram per year. The latest addition to this dosing regimen is the low dose regimen, originating from a number of low and middle income countries, including China, India, Tunisia, Thailand, and Indonesia. You can see that they've experimented with very low doses of 10 to 15 units per kg for both factor 8 and factor 9, given 2 to 3 times a week. And of course, the overall dose is somewhere in the region of 1,000 to 1,500 per year. And of course, we've got very specialized dosing regimens, such as the Canadian dose escalation regimen, where they start pediatric patients just once a week at 50 units per kg. They increase that dose to 30 units per kg twice a week, and of course, and then optimally at 25 units every other day. These dosing regimens are not the only way one can, of course, look at this. You can also look at them by therapeutic agents. We do have standard half-life, extended half-life, and non-factor therapies. And I won't go into the details. Suffice to say that each one of these has got a place when you are trying to embrace prophylaxis as the new standard of care in our patients. And of course, the most recent addition would be the non-factor therapies exemplified by emicizumab. Of course, we're looking forward to the other 5 or 6 that are in the pipeline that are currently being evaluated in the phase 3 studies. The beauty about prophylaxis is that it is actually possible at any stage of bleed control. We do talk about the different types of prophylaxis. Primary prophylaxis referring largely to joints that have never seen a bleed, and to prevent further potential and possible bleeds into those joints. That is primary prophylaxis. Secondary prophylaxis is prophylaxis being given to those individuals that have had 2 or more joint bleeds before the onset of joint disease. And tertiary prophylaxis, patients have had the onset of joint disease as evidenced by, and of course, joint arthropathy, pain, swelling, chronic synovitis. And we do talk about intermittent or periodic prophylaxis in the context of those patients, for example, who are playing games, football, soccer, if you want to call it that, who want to be protected whilst they are actually engaged in those activities. And of course, they are not taking this for 52 weeks in a year. It's less than 45 weeks in a year. That is a definition of intermediate or quaternary prophylaxis at the end of the day. What we really, really want is guidance on how to give prophylaxis. And in fact, with the publishing of the WFH 2020 third edition of the Management of Haemophilia guideline, we actually have got the prototype guidance that one is looking for. The WFH recommendations are outlined in this guideline, and I'll take you through some of the ones that are relevant to prophylaxis. And the first one that perhaps that is important is to note that the WFH declared prophylaxis as the standard of care globally, irrespective of the resource constraint that the country might be facing. essentially accepting that there is no excuse not to practice or institute prophylaxis around the world. The guideline also recommends early initiation of long-term prophylaxis with either standard or extended half-life factor 8 prior to the onset of joint disease. We do know that what you need is a single joint bleed to be able to initiate joint disease. And at the end of the day, in fact, if you can prevent that very initial joint bleed, you'll be able to save the joint from further damage. The WFH also recommends that the patients with severe hemophilia A should receive individualized prophylaxis. And we'll allude to that later on when we talk about PK-guided prophylaxis in the context of this guideline. And then finally, PK monitoring is important. And it's recommended for patients. And all of us have access to the WAPS platform, which is free of charge. You just need to take 2 samples in a patient and upload it, and it will give you the typical PK profile for a particular patient, which then you can use to optimize prophylaxis in all. Perhaps more importantly, the guideline recommended moving away from the 1% that converts patients from severe to moderate disease. It states that the 1% may be insufficient to prevent bleeds in all time. There is a lot of evidence to show that, in fact, that is the case. We aim more at more than 1%, and in most cases, at least 5% in the majority. Perhaps to take you through the rationale for early initiation of prophylaxis, there are many, many long-term benefits of early initiation. You get less arthropathy, you get less disability, as a result of which you get less need for orthopedic intervention. And of course, you do improve the quality of life of the patients. Just to give you an example of the kind of sort of prevention that one is looking at, this is data from Johannes Oldenburg, where prophylaxis is actually the norm. If one is looking at the joint score by joint location, you can see that, in fact, there are some joints like elbows that you would have thought actually have never bled. But when you measure the joint score, whether it is by the Pattison tool or by the Gilbert tool, clearly there is evolving evidence that these joints are damaged or are being damaged over time. And hence the early initiation of prophylaxis in many of these. Of course, personalized prophylaxis should be the norm. We do know that in our lives, many things are personalized, and there's no reason why people with bleeding diathesis should not have personalized care. We do know that patients should be personalized on the basis of their age and body size. We do know that genetics plays an important role in personalizing the care of these individuals. Large deletions versus other type of mutations require special care. The bleeding frequency of the patients require that, in fact, particular attention being paid to how often they bleed before you put them on prophylaxis. The joint status, we'll talk about target joints later, but the bottom line is that target joints are very, very important to identify, because ultimately, with the current tools we've got, there is a 99.9% chance that they may well be treated. Patients should be personalized in terms of adherence. Patient access to therapy. I mean, if someone lives 2,000 kilometers from the treatment center, one would want to look for therapy that would allow that individual to be able to have prophylaxis without frequent visits to the site. The coagulation capacity of the lab, and Susan is going to talk about that later on. The patient goals and needs are important in this day and age. We talk about shared decision making, and perhaps more importantly, we want physically active patients that enjoy life. And we should be able to be versatile enough to be able to cater for their wishes at the end of the day. If one looks at the importance of higher trough levels, I alluded to these in the WFH recommendations that 1% may not be enough. In fact, this study, the PROPEL study, which looked at PK-guided prophylaxis, you can see from here whether one is looking at the total annualized bleed rates, the spontaneous bleed rates in the middle, or the annualized joint bleed rates on the right, comparing the trough level of 1 to 3 to a trough level of 8 to 12. Clearly, the number of patients with annualized bleed rate is significantly higher in those with higher trough levels in yellow compared to the lower trough level of 1 to 3 in orange. What should be the recommendations to our patients in 2022? We should actually be modifying what we've been advising them. I know it is not easy, and certainly flipping is not what scientists should be doing. It's something that maybe politicians should be doing. But the bottom line, instead of saying, if in doubt, treat, if you are actually on prophylaxis and you are on these new agents, the advice should be, if in doubt, wait and see. Because in most cases, and certainly in our center, sometimes, in fact, it's not a bleed. It is something that the patients might have perceived to be a bleed. We need to start prophylaxis before the first bleed as opposed to after the first bleed. And we are now beginning to accept that we're not converting patients from severe hemophilia, which is defined as factor level of less than 1%, to mild or moderate. We actually do want them to be moderate to normal. In other words, above 5% of the factor level. And that's a recommendation of the European hemophilia community. It's something that, in fact, the global community is beginning to embrace. And I just wanted to bring this diagram back, the diagram on your right, showing the data from the Netherlands. When the prophylaxis regimens were introduced in the third cohort in the 1990s and the 2000s, you can see, in fact, a significant change in the life expectancy of the Dutch people with hemophilia compared to the general population. Again, at the top, at the bottom, a significant increase in the life expectancy of those who are receiving prophylaxis. And in fact, that experience can be extrapolated to around the world. So what we actually have come to accept is prophylaxis should be the standard of care, even in the context of resource-constrained settings such as ours. I just want to take you back to the HemoCare study that we did amongst the 4 countries that I mentioned earlier on. When we looked to see the proportion of patients who were on prophylaxis, it was a dismal less than 10%. In fact, to be exact, it was 9% of the total 280 patients that were included in the HemoCare study that we published sometime back in 2019. We do accept, of course, that various countries have got different resources, but we must also accept that South Africa is not in that league. If we look at the gross national income in US dollars per capita, most African countries, in fact, fall somewhere between 0 and 4,000, at most 4,000 US dollars. In fact, South Africa is the only one that is above 4,000, but below 12,000. So essentially, the message should be, we cannot continue as a country to accept that patients do not deserve prophylaxis at the end of the day. It is with that mindset that we basically came together as treaters in South Africa and came out with a consensus guidance document that would allow us to be able to embrace prophylaxis as the new standard of care. And of course, using the prototype non-factor therapy that is available to us in South Africa, and that is emicizumab. And in fact, this is now published at the beginning of this year in the SAMJ as an in practice. You can download it at your own time. I just want to highlight the criteria that we came out with during our deliberations. in coming out with this consensus guideline. Let's start off with the consensus criteria for hemophilia A patients with inhibitors. It was our view, supported of course by extensive literature data, that patients with annualized bleed rates of more than 4 should be put on prophylaxis. And I've already sort of alluded to that when I presented the data on extended half-life, that none of the patients who were on extended half-life had an annualized bleed rate of more than 4. And there's no reason why, in fact, our South African patients should be having annualized bleed rates of more than 4. And the second one is that patients with a history of or at high risk of live or organ-threatening bleeds. We're talking here about intracranial bleeds and bleeds into the eyes and other sensitive organs. Extensive literature has shown that if you put these individuals on prophylaxis, especially if they've got inhibitors, you may well save that organ that may well die or disappear as a result of a single bleed. Patients with an ABR of less than 4, with poor response to the traditional treatment for inhibitors, which are bypassing agents, should ideally be put on emicizumab prophylaxis. Patients with poor venous access, this is often regarded as a very soft indication for putting patients on prophylaxis. But the reality on the ground is that the reason patients bleed is sometimes because they simply do not have venous access. In a different presentation, I illustrate this by showing that if you are actually on prophylaxis 3 times a week, you need to inject yourself 3,120 times when you turn 20. And you'll agree with me, injecting yourself 3,120 times, that is not what the veins were meant to do. So those individuals should ideally be on prophylaxis. And of course, patients with target joints, these are joints that bleed frequently. And of course, there's different definition. Our definition is 3 bleeds in 6 months. Those patients should actually be on target joints. And then finally, this was a consensus opinion among the South African experts in hemophilia, is that patients with circumstances where there is no alternative options deemed viable for treating these patients, as of course judged by the healthcare professional. And there are many such instances we can talk about in the discussion, but it is important to keep these criteria open in that way, because sometimes people stick to the criteria and they forget that we deal with human beings and the decisions in fact are made by human beings. What about the consensus criteria for those without inhibitors? We came out with similar but not identical criteria. For those without inhibitors, patients who are bleeding with a very high bleed rate, an ABR of more than 4, despite factor 8 prophylaxis, patients with a history of organ or life-threatening bleeds, patients with poor venous access, patients with target joints. These are exactly the same as those in the inhibitor patients. And of course, the last one is also the same as those in the context of inhibitor patients. So if I were to sum up and perhaps leave everything for discussion, I hope I've illustrated to you that prophylaxis is now the globally accepted standard of care in hemophilia. Therapeutic agents have evolved over the years to include extended half-life and non-factor therapies, and that our therapeutic goals in hemophilia have also evolved. We are looking for optimal bleed prevention, joint health, optimized physical activity, etc., etc. Beg your pardon. And the current prophylactic regimens, in fact, are versatile enough for us to be able to put any patient on any regimen and still achieve better results than episodic treatment. And then finally, with the last bit, it is absolutely important, particularly for those of you in the audience who are not regular hemophilia treaters, that there is actually a consensus guidance in South Africa. We've established a criteria for putting patients on emicizumab prophylaxis, those with hemophilia A with or without inhibitors. And it is our hope that this criteria will be the foundation for establishing prophylaxis as the new standard of care. With that, I would like to thank you all for your attention and good afternoon from the not so cloudy Johannesburg. It is now my pleasure to perhaps welcome Susan Low, And the plan between Susan and myself is to allow her presentation to go through and then take questions at the end. Susan, I'm going to stop sharing and you go ahead and share your presentation, please. We can see your presentation. If you can put it on presentation mode, thank you.
Good afternoon, colleagues. An informative platform that you guys have established. I think it was during the time of the pandemic, so and I'm even going to get my laser pointer up and going. My name is Dr. Susan Lowe, and I am a hematologist. So we are going to step into the laboratory, but there's always a patient standing behind a sample in the laboratory. So I am going to dip out of the laboratory and enter into your realm, that being the realm of clinical hematology. So this afternoon, we're going to discuss laboratory assays in the diagnosis, management, and monitoring of patients with hemophilia. Normal hemostasis is all about balance, and I hope that person that's standing right over there has got just that, very good balance. And the hemostatic system ensures blood stays in a fluid state inside the vasculature, preventing blood loss at sites of injury, forming a hemostatic plug. Ultimately, there's clot removal or fibrinolysis once healing is complete. And then patients, obviously, with a bleeding diathesis, such as patients with hemophilia, there's a problem with formation of appropriate blood hemostatic plugs. Hemophilia is the story about the missing coagulation factor. I don't know about you guys, but I remember playing dominoes as a child. We didn't have shifts and DSs and all those kind of things. So there's in patients with hemophilia, there's a missing coagulation factor. In the laboratory, as hematopathologists, we divide the coagulation cascade into two arms, namely the intrinsic pathway and the extrinsic pathway. It just helps us in the laboratory to understand what's happening with patients, and we can then conduct various coagulation assays and make conclusions and ensure that patients are treated appropriately. But if we speak about hemophilia, hemophilia A is the most common form of hemophilia, as we all know, with abnormalities of factor VIII, affecting about 1 in 5,000 male patients. Hemophilia being a defect or abnormality in factor IX, and hemophilia C being defective coagulation factor 11. We can see that all of these factors are in the intrinsic pathway. And when we assess the factors in the intrinsic pathway, we rely on a test that we all very well affay with, that being the activated partial thromboplastin time. Because all the factors in the intrinsic pathway eventually aids in the formation of a fibrin clot, and that is the end of the assay, of the time to clot assay, the assay being the APTT. And Professor Mashlangu and everybody on the call is very aware of and has seen all of these clinical presentations in patients with hemophilia. And we also know about the disused muscular atrophy and the contractures. And obviously we want to prevent patients with hemophilia from ever having this very end organ damage, and namely the severe arthropathy that's associated with hemophilia. We are going to spend more time on hemophilia A, since it is the commonest form of hemophilia, but what we will discuss will also pertain to hemophilia B and C. So firstly, the diagnosis of hemophilia A. I don't have to embroider and embark on discussion around the clinical manifestations because those are very well known to us. When we then step into the laboratory in patients that are suspected of suffering from hemophilia, the hallmark finding is that of a prolonged activated partial thromboplastin time, because one of the coagulation factors in the intrinsic pathway is defective, resulting in prolongation of this time to clot assay. And then we also are tasked with determining the actual factor VIII level in patients suspected to suffer from hemophilia A. These patients can be divided into grades of severity, namely mild, moderate, and severe, depending on the actual endogenous factor VIII level. But there's now also the concept of mild, severe hemophilia patients. Those are the patients that in the laboratory seem to be suffering from severe hemophilia A, in that their factor VIII levels are less than 1%, but phenotypically they are behaving as patients with mild hemophilia. It's not completely clear why, but there's possibly underlying prothrombotic mutations related to different mutations in the factor VIII gene, as well as inaccuracy. And I say that as a pathologist, some laboratory tests are actually inaccurate that come from the laboratory because there is difficulties in the laboratory to actually define the levels at this very low level of factor concentration. Additional assays will therefore also be required in the future, such as thrombin generation assays, since patients with this mild, severe phenotype generate more thrombin, and that can be ascertained with an assay such as the thrombin generation assay. And then in comes another assay, the chromogenic factor assay, which we will discuss. We also know that our colleagues in the genetics unit is very important in that we can ascertain the underlying genetic mutations in patients that suffer from hemophilia. But back to the laboratory tests. It's all about the activated partial thromboplastin time, or is it? The APTT evaluates the factors in the intrinsic coagulation pathway, and it is the time needed to form a fibrin clot measured in seconds. We're all well aware that we have to collect blood in a citrate tube. It needs to be completely filled with an atraumatic phlebotomy. Citrate, being negatively charged, binds to the calcium in the blood, and once calcium is removed from blood, it is unable to form a clot. We have anticoagulated the blood. Then APTT reagent is added to the citrate plasma. APTT reagent contains phospholipids and also a contact activator in the form of either actin or silica to initiate clot formation. Once the calcium is added, the stopwatch starts, and once a fibrin clot is formed, the clot watch is stopped, and we have measured or ascertained an APTT in seconds. And this is just a donation, a picture of what I've just gone through. So how do we then determine the factor VIII concentration or the factor VIII level with an APTT assay? The one-stage or APTT-based factor VIII assay measures the extent to which plasma from a patient corrects the prolonged APTT of plasma completely deficient in factor VIII. So this plasma completely deficient in factor VIII is commercially available to us, and we buy that from manufacturers such as Siemens or Stego. This is being mixed then with the patient's plasma, and then we determine the APTT in this new plasma. And we report the factor VIII either as percentage or international units per mole, and that is done according to a calibration curve. We measure seconds, so we measure how long does it take the sample to form a clot. The longer it takes the sample to form a clot, the less the factor VIII level is. And the quicker the sample forms a clot, the higher the factor VIII level is. This assay can, however, miss patients with mild hemophilia. And if another anticoagulant is present, such as a lupus anticoagulant, which behaves as an anticoagulant in the laboratory, although it is prothrombotic phenotypically in patients, will falsely lower the factor VIII result. So this being the one-stage APTT-based assay to determine factor VIII levels. When we then go towards, when we then look at the chromogenic factor VIII assay, we see that this is a completely different assay in that purified factor IXA now serves as the catalyst to start the coagulation cascade. This is combined with factor X, also exogenously added to the test plasma. Thrombin can or cannot be added depending from which manufacturer we obtain our chromogenic reagent. This is added to the test plasma. There's an incubation step, and there's factor Xa now generated. The amount of factor Xa that is generated is measured by the release of a chromophore from a factor Xa specific substrate. And the amount of factor Xa generated is proportional to the factor VIII activity in the sample. So just as a picture, factor IXA is added together with the patient's factor VIIIa, activates factor X to factor Xa, which is an enzyme which acts on the substrate. Chromophores are released, color is generated, and the more color that is detected on an optical density platform, the more color there is, the higher the factor VIII level. What about the one-step APTT-based assay versus the chromogenic factor VIII assay? Are there discordant results sometimes obtained in patients with hemophilia A? And obviously I'm asking this question because the answer is yes. It depends on the pathogenic variant in patients with hemophilia A. For example, patients with missense mutations in various areas of factor VIII gene can result in the discrepant factor VIII result between the one-step APTT-based assay and the chromogenic assay. Patients with mutations in the factor VIII gene where factor VIII actually interacts with thrombin or with factor IX or with von Willebrand's factor can also have discrepant results depending on whether we perform a one-step assay based on PTT or whether we perform a chromogenic assay on these patient samples. When it comes to inhibitors, because the laboratory is also tasked to determine whether patients with hemophilia have developed inhibitors. As we all know, inhibitors can also occur spontaneously, reacting in the very serious condition of acquired hemophilia. But in the laboratory, we will then be performing a Bethesda assay. Now, a Bethesda assay relies on, again, patient's plasma, cytoplasma. There is no factor VIII in this patient's plasma because the patient suffers from severe hemophilia A. This is mixed with normal pooled plasma that contains a factor VIII level close to 100%. When you mix a plasma without any factor with 100%, you expect the result to be 50% or greater. If the result of the factor VIII level in the mixed plasma is less than 58%, we suspect an inhibitor. And if the result is equal to or greater than 50% in this patient's example here without any inhibitors, we can then safely say that an inhibitor is not present. And then by denotation, a factor VIII activity in the mixed plasma translates to the strength of the inhibitor with 50% inhibition of the factor VIII denoted to the mixed plasma from the normal pool being a Bethesda strength inhibitor of 1. There's also the Niemann modification, which I won't go into detail because I can see that the clock is running. But the Niemann modification of the Bethesda assay then involves buffering of the plasma in the lab to a pH of 7.4. So we are trying to recreate the situation in the body in vivo, because we do understand that these inhibitors are active and need to inhibit coagulation factors. So the plasma is buffered to a pH of 7.4, and we also use immunodepleted factor 8 deficient plasma in this assay. And it's thought that, or it has been demonstrated, that this modification results in better discrimination between patients that has or has not developed factor 8 inhibitors. The timelines of the treatment, Johnny has elucidated for us in his talk. So I'm just going to leave it there for a second so everybody can just familiarize themselves again, that we are now bound to meet patients in the corridors of hospitals that suffer from hemophilia that has now had gene therapy. In the lab, we also involve ourselves with monitoring of treatment. So what does treatment constitute? And Johnny has also very in-depth discussed this prophylaxis with us. We are also tasked to treat patients when there's breakthrough bleeding. We have to get rid of inhibitors. We have to monitor inhibitors. We have to use bypassing agents in patients that have got significant inhibitors. And then obviously also the treatment and the rehabilitation of joints that have been affected. So what is in the toolbox? And I was looking for a good word, and then Johnny used this word toolbox. So what is in our toolbox when it comes to the treatment of patients? We know that we can just simply administer coagulation factors, and this is just a list of the coagulation factor concentrates that are available, factor 8 concentrates, the factor 9 concentrates, and these half-lives you can see in front of us over here, the half-life of the factor 8 concentrates being shorter compared to the half-lives of the factor 9 concentrates. And these concentrates are either plasma-derived or recombinant. And then we've also spoken about how to extend the half-life of the clotting factors, infusing the clotting factors either with proteins or pegylating the coagulation factors. We can even alter the sequence and prolong the half-life of the factors that we infuse in patients. On the screen, you can see the currently available and authorized factor concentrates that have got extended half-life for patients with hemophilia A and patients with hemophilia B, and the companies that manufacture these factors for us, and also the mechanism of half-life extension up to 102 hours and beyond. But in the lab, if we are then tasked with identifying or measuring the coagulation factor 8 levels in these patients, we have to be wary of what these extended half-life factors consist of, because again, we can see that there's now discrepancy between the one-stage APTT-based assays and the chromogenic assays, depending on which extended half-life factor is being utilized and is being administered to the patients. We also are aware of the bypassing agents that are available to us in patients with coagulation factor inhibitors, and sometimes the lab even have to determine and perform various tests in these patients to ascertain whether we have achieved hemostasis. Then we are now in the realm of non-factor replacement therapies. These factor replacement therapies have got various advantages and also various challenges. And we are aware that the advantages include that we can administer these agents infrequently with subcutaneous injection and utilize these agents in patients with inhibitors and patients without inhibitors. There are also challenges in that these non-factor replacement therapies are not indicated for the acute management of bleeding in patients. There's limited hemostatic monitoring available in the laboratory. There's also limited data for the management of surgical procedures, although I did see that Johan Potgieter was on the call and he gave us a very detailed, very interesting talk on surgical procedures in patients on non-factor replacement. So we are starting to find our feet even in this realm. And then we also have to be careful about thrombotic events and thrombotic microangiopathies developing in patients on non-factor replacement therapies. And here they are, the new kids on the block, the novel hemophilia treatments based on non-factor replacement therapies. If we look at humanized bispecific antibodies mimicking factor VIIIa activity, imizumab, but there's also MIP8, Kymab. If we are inhibiting the natural anticoagulants with, for example, short interfering RNAs, we can inhibit antithrombin, fitusiran. We can inhibit the activated protein C with Apsintex. I'm sure there's going to be a more user-friendly name for this drug. And we can also employ tissue factor pathway inhibitors in order to assist with hemostasis in patients that suffers from hemophilia. But let's just concentrate for a moment on the novel hemophilia treatment called imizumab. The trade name Hemlibra, I must say, is easier to pronounce. What is imizumab? Imizumab is a bispecific monoclonal antibody that forms factor 10A in the absence of endogenous factor 8A. With a long half-life, we can administer it weekly, and we can utilize it in patients with and without inhibitors. What happens to patients in the laboratory? So once we have a patient sample, and we always try in the laboratory to remember there's a patient behind the sample, but once the sample is in the lab and there's imizumab in the sample, imizumab will result in a shorter APTT compared to normal factor VIII. Factor VIII requires natural factor VIII or factor VIII that's infused in a patient, whether it's the standard half-life factor VIII or the extended half-life factor VIII, requires additional time in the laboratory to activate thrombin, thrombin being coagulation factor 2, and thrombin having the ability to convert fibrinogen to fibrin, fibrin being clot. So if we perform an APTT in patients that does not have imizumab, it will take longer for fibrin to form compared to patients that is on imizumab therapy. So if we look at standard assays, such as the APTT, the results in hemophilia patients on imizumab, they will be normalizes at low concentrations of imizumab, even if endogenous factor VIII is significantly low. The factor VIII one-stage activity assay is dependent on APTT, as we've seen earlier in the presentation, and this will normalize the APTT factor VIII assays at very low concentrations of imizumab. The factor VIII chromogenic activity assays based on bovine factors. So what factors are we talking about here? We obviously, for those people that are still awake at this time in the afternoon, we rely on factor 9A and also factor 10 exogenously. If these factors were donated by our colleagues in the animal world, so donated by cattle, this assay will be insensitive to imizumab and will accurately determine the factor VIII levels in patients on imizumab therapy. If, however, the factor 9 and the factor 10 comes from human donations, or if we've manufactured in the laboratory, but very similar to human factor VIII, these assays, although they are chromogenic assays, will be sensitive to imizumab therapy and will be reporting the factor VIII due to the activity of imizumab in the sample. So if we want to determine the factor VIII assay in a patient on imizumab therapy, we have to reach out and dig deep into the fridges in the laboratory and find chromogenic factor VIII assays based on bovine coagulation factors. just again a picture, just to say that the chromogenic assays based on human factors come from manufacturers such as Hyphen and Stego manufactures a chromogenic factor 8 assay based on bovine-derived coagulation factors, which is then insensitive to any imizumab action. What about inhibitors in these patients? And if we just remember the Bethesda assay, all we do in the Bethesda assay is we just assay factor 8 levels. Once we've mixed the patient's plasma with plasma that contains 100% coagulation factor 8. So it will hold true that the Bethesda assay based on the one-stage factor 8 method, which is the APTT factor 8 method, will yield false negative results when we are trying to determine whether a patient has developed inhibitors to factor 8. That factor 8 being their own factor 8 or factor 8 that's very similar to human factor 8 and is infused in the patient. Whereas Bethesda assays based on bovine reagents to determine the factor 8 level in a chromogenic assay will be unaffected by imizumab and will give us a true reflection of whether the patient has developed inhibitors to coagulation factor 8. What about the interference with other routine assays in the laboratory? In patients on imizumab therapy, there will be no effect on immunoassays such as D-dimer assays or on chromogenic assays such as antithrombin assays or assays triggered by thrombin such as the thrombin time. As pathologists in the hematology lab are actually quite simple people. So if we rely on thrombin to generate a clot, we just call the assay a thrombin time. Imizumab will have a weak effect, but detectable effect on INR, which is PT derived, PT being prothrombin time, and it will also have an effect on the fibrinogen levels that we generate with the class method. But in patients on imizumab, there will be a significant effect on the APTT and on all APTT-based assays, such as proteins S, activated protein C, the classic Bethesda unit, and the activated clotting times will all be will give false results in patients on imizumab therapy. So I've seen the future, but I've signed a non-disclosure in that in the future, we will probably have to rely on assays such as the thrombin generation assay, since this assay measures the full cascade and will be able to give us a true and an accurate reflection of the hemostatic capacity in patients with hemophilia on various forms of therapy. There is, however, high variability and a lack of standardization in the methods and the reagents that are utilized in, for example, the thrombin generation assay. But in the future, we will find our feet with these new forms of assays in the laboratory as well. So just to summarize, imizumab enables clotting even in the presence of factor 8 inhibitors. The clot-based Bethesda assays in these patients will give a false negative result in patients on therapy. There is no time needed for imizumab activation. So the time and intrinsic based assays such as the APTT and the one-stage factor 8 assay, even the ROTEM, will overestimate the factor 8 activity in patients. And that being the endogenous factor 8 activity, not so it will reflect the imizumab activity in the patients. And imizumab does not bind to bovine factor 9 and 10, so there will be no imizumab activity detected with chromogenic factor 8 assays based on bovine factors. So I trust, and in the speed train that I was on, that as far as laboratory testing in patients with hemophilia, I was able to take you from this situation to a calmer situation, which I'm sure is in the beautiful province of the Orange Free State. Thank you very much for your attention. and hoping to answer any questions that you may have. Thank you.
Thank you very much, Susan, for taking us through that detail on measurement of factor VIII inhibitor in the presence of emicizumab. I think that is a very, very important aspect of the evolution of us embracing the new tools in the toolbox. We do have some time. It is 16 minutes past 5. And I think we've got a couple of questions in the chat. I just want to see if there are any hands being raised. I'm going to recognize Tanya, who is unmuted. Tanya, please go ahead before we take the questions in the chat.
Oh, sorry, Prof. I accidentally unmuted myself.
Ah, okay. I thought you couldn't wait to speak, Tanya. Okay. So
it happens, but not today.
There are two questions that are in the chat at the moment. The one is from Jacques, and Jacques wants to know which extended half-life agents are available in South Africa. Jacques, it is an unfortunate situation that there isn't actually any of the extended half-life agents that are available commercially. Having said that, I think the global experience on 6 or 8 of these extended half-life, in fact, largely comes from South Africa. So there is experience, but they are not registered for a number of reasons, which we will not go into at the moment. In fact, the last contact I had was at the beginning of this year, where the factor VIII FC, a lactate, was in the process of being registered in South Africa. As you know, we basically drove many of those programs. And in fact, some of our patients were on a lactate for about 7 years post-trial. So we hope that at least one of them would be registered in South Africa soon. And in fact, I must just, that reminds me to contact the commercial company and find out how far they are. The last time I spoke to them, they were actually submitting, and they wanted a motivation from me. And the second question comes from Nolu Ncete. Dr. Ncete wants to know, thank you for an excellent presentation. Is there any data on the percentage of patients on prophylaxis in South Africa? Nolu, yes, there is indirect data. In fact, there is several data sets. It's a matter of us at some stage being cohesive and producing a single data set. If you look at the World Federation of Haemophilia annual global survey, we do submit data, and we admit that, in fact, the data that is being submitted through that channel is probably not the most accurate. The most accurate data is obviously at individual hemophilia treatment center level. And when we did the survey several years ago, I think about 4 or 5 years ago, we discovered that actually the uptake of prophylaxis varied across the 23 hemophilia treatment centers. With some centers like ours, almost 80% of the patients on prophylaxis, to very rural environments and centers draining those with patients not on prophylaxis, and some of them as low as 5%. So we don't have uniform data, but with the initiative of Estelle and Venon, hopefully a localized registry will allow us to be able to measure that better in the future when the data comes together. I see that there is a hand up by Johan. Johan, go ahead, please. Johan Potgieter, you've got your hand up.
Yes, Johnny, thanks. I must say that I think Eloctate and the factor IX is registered extended half-life products by SAHPRA. It's just that they're not marketed. So the company has decided not to launch because of a business decision, and not so that at least one factor IX and one factor VIII extended half-life are registered with SAHPRA and are just not marketed.
Yeah, my take on this was they needed to submit additional documentation in order to undergo the marketing exercise. You're absolutely right. It is, in fact, the very first extended half-life product to be available globally. And at the time, the COGS were the ones that were preventing, cost of goods were the ones that were preventing the marketing. And it looks like, in fact, there are people who are willing to take that process forward. Thanks, Johan, for recalling that correctly. But I think that there still need to be additional submissions before they can market the drug. There is another point being made by Moses. How practical do you think it is to institute prophylaxis for severe hemophilia A before they have their first bleed in the South African context? Moses, it really is as practical as making a diagnosis. Our experience is that if you've got a family history and you do expect someone with hemophilia to be born, one can always start prophylaxis before the very first bleed. And that is actually the practice elsewhere in the world. The difficulty comes in with a 30% spontaneous mutation that we see in hemophilia, where it is not possible to sometimes predict who's got hemophilia and who hasn't got hemophilia until they phenotypically present with bleeds. But definitely it's something that is being practiced and being implemented elsewhere in the world, Moses. And then there is another question. I'm interested to know if we have any visitors from outside South Africa today. If yes, please name your country in the chat box. This is not a question to me. This is Vernon marketing the deep dive. Please, if there are any visitors in the platform that are from outside South Africa, just name your country in the chat so that Vernon can keep the stats and certainly can invite you to join. Johan, I'm not sure if your hand is an old hand or a new hand.
It's actually a new hand, John, and I think the challenge is going to be if we have access to a larger armamentarium of drugs that we know as, let's say, lab hematologists also, what the patients are taking, because all of that will influence the type of tests that you're going to have to do, the type of reagents that you're going to use in terms of what your activating factor is in your APTT, if they are in extended half-life products, and if the patient is on a non-replacement therapy, So I think that needs to be clear. And for a long time, I've had lots of respect for the labs in other African countries that were purely dependent on product that was donated by the World Federation of Haemophilia to be able to analyze what they were dealing with, because now it's more structured and they get the same product designated to patients. But before, they could get extended half-life or standard half-life, recombinant or plasma derived, and they had to make it work, So I think that's going to be the challenge for us going forward if we have access to a lot of drugs.
No, thanks, Johannes. I think your comments are absolutely spot on. They are very much valid. My only worry, especially with your last comment, I think we are being overtaken by many of the African countries. By the way, just as an example, our factor usage per capita is only 1.2, as I showed in my presentation, compared to Mauritius, which is over 4. Now, you could argue that Mauritius could not, and certainly is not, as wealthy as South Africa. And the question, of course, is why are we not having higher per capita usage? Last week, in fact, Susan could tell you a little bit more about this patient. I received a patient from Mozambique who needed to have a pseudotumor removed. This patient was actually on emicizumab in Mozambique. And if I ask the same question in South Africa, probably it's a handful of centers that would be on emicizumab. Whereas in Mozambique, actually a large number of these patients are on emicizumab. I've got a couple of questions that we've still got time. We've got 5 minutes. Perhaps before I take Garek's question, I just want to welcome on behalf of Vernon, a number of people from outside South Africa. There is Guta Gilta from Harare in Zimbabwe. There is Elizabeth Botsile from Botswana. Welcome. There is Wilfred Shakumba from Zimbabwe. Welcome. And then there is Livingston Togara from Nigeria in Kaduna. And there is Lavinia from Namibia. Welcome to all of you on behalf of Vernon. In fact, I see Vernon has already welcomed you into the deep dive platform. Back to Garek. Garek is asking, are there any studies that look at a cost comparison of gene therapy versus clotting factor concentrate therapy on demand or prophylaxis over the expected lifetime of an individual? I mean, it is obviously a pertinent question. It's something that talks to access, Garek. And the bottom line is, it's literally chalk and cheese. Susan was mentioning earlier on that you could be walking around the hospital and meeting patients who have had gene therapy. We've just had over 40 patients who have had gene therapy in our center. And it takes the cost from millions to zero in the majority of those patients. Of course, it depends on whether the gene therapy works and also how well those patients respond to gene therapy. So the cost comparison is actually something that has been done by NIS and a whole host of other organizations such as ISA. I haven't seen a study specifically looking at gene therapy versus clotting factor, but studies comparing non-factor therapy to extended half-life to standard half-life have all been done. And in fact, as you progress through the evolution of the therapeutic landscape, the cost become less and less over time. And I would just want to see if there are any other questions. And perhaps to put Susan's talk into perspective, Susan was asked to set up this chromogenic assay for emicizumab, mainly for those individuals that would like to accurately measure the factor level in the presence of emicizumab. And maybe Susan could just comment on how well used this assay is in her lab.
Thank you, Johnny. Yes, I was just busy and I typed too slowly, but there was a question around the assay. So both the APTT-based and the chromogenic factor assays can be automated. We've set both of these assays are available on our automated coagulation analyzers. So, and they are both conducted on one citrate tube. That's all that's required. So it's not as though this is a difficult assay or an assay that requires a lot of expertise or hands-on. They can be set up in the laboratory as long as the reagents are available. The quality control measures are the same for both assays. The IQC material is utilized, is the same for both assays. So these are not difficult assays or labor-intense assays, and as long as they are validated and the quality measures are applied, they can be conducted in most well-equipped coagulation laboratories.
Thank you, Susan. And there you are. We do have the assay set up and running, and I'm sure Susan will be able to share with you the SOP if you want to set it up. And certainly would encourage everyone to use them where it is clinically indicated. With that, it is exactly 5:30. It remains for me to thank all of you for taking time off your busy Monday to come and listen to myself and Susan, and certainly for your contribution to this platform. And I would like to thank people from outside South Africa for seeing it of value to join us here. I'm going to hand over to Vernon to close the session.
Johnny, Susan, thank you so much. What a fantastic session. was super well attended. At one point, we were more than 160 people in the room, which is really, really wonderful, and just shows how important this topic is to so many people. Much, much appreciated the time you took to make difficult concepts easy for us, or easier at least. So it was really wonderful. I also want to close with a thank you to Prof. Estelle Verburg, Dr. Elzaan Jansen van Rensburg, who does the logistics and the organizing, as well as Melanie Davids, that's quite involved with some of the administration, as is Jani van Wyk. So thank you very much and have a lovely evening. Next week, we'll talk about relapsed refractory lymphoma, and the speakers is going to be the very famous local Dr. David Britton, relapsed refractory Hodgkin's lymphoma, and the internationally well-known Pier Luigi Zanzani, which is a great privilege to have him in the room next week. So please welcome your colleagues, make sure as many people as possible attend. I think it's going to be a great learning opportunity. All the best, everyone. Bye-bye.
Bye.